Good afternoon, everyone. My name is Srishti Goyal, and I'm a placement student currently completing my Master's of Social Work placement at Mental Health Foundation Australia. I'm honored to be your host for today's webinar. I would like to begin by acknowledging the Wurundjeri Woi people as the traditional custodians of the land on which I live and work. I pay my deepest respect to their elders, past, present, and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people joining us today. On behalf of the Mental Health Foundation Australia, I warmly welcome you and thank you for joining us for today's session. Women's Mental Health and Neuropsychology, an update on how hormonal shift impact cognition and mental health. Today's presentation will discuss how hormonal change can influence cognition and mental health across different life phases in women. There will be a focus on menopause, brain fog, as well as the intersection between menopause and ADHD. The session aims to begin our understanding of neuropsychological changes women may experience and how this shift can affect daily functioning and well-being. Let's get started. It's my pleasure to invite our presenter, Associate Caroline Gurvich. Caroline is an associate professor and a clinical neuropsychologist. She is the Deputy Director of HER Centre Australia, Monash University, head of the Cognition and Hormonal Group, and chair of the Victorian College of Clinical Neuropsychologists. Caroline's research interests are related to the neuropsychology of women's mental health. She is particularly interested in how cognition and mental health can be impacted in some women at time of hormonal change, such as menopause. Caroline has over 100 publications that has contributed to a better understanding of cognition and mental health and mental illness. Caroline also works as a clinical neuropsychologist in private practice. Please join me in welcoming Associate Professor Caroline Gurvich.
Thank you very much, Srishti, and thank you to everyone for inviting me to present today. I'll just make sure you can see my slides okay?
Yeah.
Excellent. All right, so as Srishti said, I'm going to talk a little bit about women's mental health and neuropsychology, and I'm going to talk a bit briefly about how hormones and mental health might be affected across different significant points across the lifespan in terms of hormonal changes. I'll talk a little bit more about menopause transition and the role of brain fog, and then the second part of it, or the end, is more about clinical considerations, and that's where I'll touch a bit more on ADHD, and then look forward to answering any questions at the end. So I'll try and speak for about 45 minutes. Okay, so people are probably aware that there are sex or gender influences on a whole range of different neuropsychiatric conditions, neurotypes, neurological conditions. So, for example, Alzheimer's disease, neurodegenerative condition, is more prevalent in females. Autism and some of the other neurodevelopmental conditions or neurotypes are more prevalent, particularly in boys, particularly in childhood in boys. And there are lots of different reasons as to why we see differences between sexes and genders in a whole range of neuropsychiatric conditions. So some of these things are related more to the socio-cultural construct of gender and societal expectations and societal norms. So there is certainly a gender-based role. And then there are a number of biological factors. So some of these factors might be more related to sex chromosome factors, and some are related to sex hormones. And that's what I'm going to focus on today. So some people might think, well, what do sex hormones have to do with mental health? Don't sex hormones in females regulate ovarian function? Don't they regulate reproductive function? And yes, of course, that's one of their primary functions. However, our sex hormones, so estrogen, progesterone, they actually cross the blood-brain barrier, and they can have quite profound effects in different brain areas that are really important for things related to mental health. So our cognition and our mood regulation and our mood itself. So just a really, really brief overview of how our brain really broadly relates to neuropsychological function. This is obviously a simplification, but just to give you a broad overview, I just wanted to highlight two brain areas that I'll touch on in the next slide. So the frontal lobes in lighter blue here, are really important, as most people will have heard of, for things like our executive function. So our higher order thinking skills, our ability to solve problems, our ability to decide what to direct our attention to set goals, to make decisions. It's really kind of the home of our behavior and personality. And then I wanted to highlight in green at the bottom, our temporal lobes. So our temporal lobes are really important for memory. So it's where our hippocampus sits, so very important for memory function. And also it's where our whole limbic system, our amygdala sits. It's really important for regulating our emotions. It's our emotional center of the brain. So keeping those blue and green areas in mind, this is a more schematic diagram with the frontal lobes in blue highlighted again and the temporal lobes in light green highlighted again. And what you can see is estrogen receptors, so they're dark red triangles, and progesterone receptors, the dark blue circles. And you can see that they're actually quite densely located in these brain areas that I've just explained are really important for regulating our thoughts, regulating our behaviors, as well as our emotional centers and our memory. So when we have changes to our sex hormones, these receptors respond to those changes, and there's a rationale as to why they might have an effect on these cognitive and mood aspects of our functioning. And the other thing this slide highlights, and I should say this slide is like an overview of a lot of animal studies. So most of this research that this slide was based on, and the publication references at the bottom there, is based on a lot of animal research. And what they've also found is that estrogen and progesterone also interact with a lot of neurotransmitter pathways that are really critical for lots of neuropsychiatric conditions, as well as regulating mood and cognition. So you will have heard of probably all of these pathways: the glutamatergic pathway, the GABAergic pathway, dopaminergic and serotonergic. So the dopaminergic pathway we know is really important for our motivation, regulating our attention. Serotonergic is also really important for regulating our mood. So again, some more scientific rationale as to why changes in sex hormones might have an impact on our mental health and our cognitive functioning. So for females, for women, for people assigned female at birth, there are certain points across the lifespan where there are differences in our sex hormones compared to males or people assigned male at birth. So the very first time is in utero, where the male fetus actually has this surge of testosterone that the female fetus does not have. And this is thought to potentially play some sort of role in creating some differences in brain organization at this very early stage. It also has differences in how our reproductive organs are formed, but in terms of brain, there is thought to be this very early difference that emerges at this fetal stage. And then the next stage that is quite relevant for the role of sex hormones is puberty. So puberty is also a sensitive period for psychosocial change, but changes in sex hormones at this time are also thought to play a role in brain activation patterns. So for females, the onset of puberty also coincides with the onset of a menstrual cycle. So our menstrual cycle is roughly a 28-day cycle where there are cyclical patterns of estrogen, so the estrogens in orange here, that fluctuate. So there's the follicular phase, which is the first half of the menstrual cycle up to ovulation, and you can see there's a peak in the orange line in estrogen. And then in the second phase, which is the luteal phase, you can see that there's a peak in the green line, progesterone, and a smaller peak in estrogen. So often our menstrual cycle research is conducted by looking at what happens during that follicular phase and what happens during that luteal phase. So what we've learned about the menstrual cycle is that in that luteal phase in particular, when progesterone peaks, about 80% of women will experience at least one psychological or physical symptom. And about 10 to 20% of women will experience what we call a premenstrual syndrome, PMS, you will have heard of. And this can be a mixture of mood, physical, or behavioral symptoms. And then somewhere between 3 and 8%, depending on which literature you read, will meet diagnostic criteria for premenstrual dysphoric disorder, which is like a very significant, clinically significant premenstrual depression, where people can experience a distressing mix of different mood symptoms, physical symptoms, and behavioral symptoms. And mostly they occur in this premenstrual phase, and mostly they resolve after menses, and then people feel okay again. But if you think about this occurring for a week or so out of every 4-week menstrual cycle, that's a significant chunk of someone's life to be feeling terrible. So this is just an overview of some of the symptoms that might be experienced as part of the PMS spectrum compared to the PMDD spectrum, aligning with the DSM-5 diagnostic criteria of both PMDD primarily. So a lot of the symptoms are related to changes in mood and changes in concentration, feelings of overwhelm, different sorts of negative mood-related symptoms, as well as some physical symptoms as well. So we don't completely understand why some people develop premenstrual depression or PMDD, premenstrual dysphoric disorder. But what we do know is when you measure at a peripheral level someone's hormone levels, they're the same as someone who doesn't have PMS or someone who doesn't have PMDD. So what we think is that the same hormone fluctuations are happening, but some people have an increased sensitivity to these normal fluctuations in hormones across the menstrual cycle. And we think that one factor might be genetic. So there's not a particular gene, but a few different genetic variants have been nominated that might make some people more susceptible to experiencing depression and mood and cognitive changes in this premenstrual phase of the menstrual cycle. And in particular, it's thought that people are quite sensitive to one of the progesterone metabolites. It's called allopregnanolone. And another factor that we think might make some people more sensitive to hormone fluctuations and hormone changes is people who've had a history of trauma in their life. So a trauma history can lead to changes in someone's HPA axis, which is the hypothalamic pituitary adrenal axis that regulates our stress response. And physiologically, there is sort of overlap between this stress endocrine response as well as the reproductive endocrine, which is the hypothalamic pituitary gonadal axis. So it's thought that perhaps this trauma history can make people more sensitive to other endocrine system changes, so the reproductive hormone changes. So there's a few different hypotheses. There's also what we see in different psychiatric conditions and different sort of brain types and experiences is that some people, rather than having PMDD, they have a premenstrual exacerbation of an underlying condition. So again, sensitivity to hormones or an interaction between menstrual cycle and the underlying condition. So we can see a premenstrual exacerbation of things like mood disorders, psychotic disorders, anxiety disorders, as well as ADHD. And again, it's hypothesized that this is a heightened sensitivity to those normal fluctuations in ovarian steroid hormones, estrogen, progesterone. So if someone wants to kind of read more, that's all I'm really going to talk about in terms of PMS, PMDD, premenstrual exacerbations. I've just put a reference to this website that's got a lot more resources. And in terms of any kind of clinical or research, the work that people wanted to do and really understand what's happening to someone across their menstrual cycle, there's a scale called the Daily Record of Severity of Problems, DRSP, and it's a 28-item scale. And what we use it in research, but also clinically, you can use it to track someone's menstrual cycle and their associated symptoms across 2 menstrual cycles. So diagnostically, it's recommended that you have prospective tracking of someone's menstrual cycle so you can see changes. And this is a research way that you can do this, or you can do this clinically as well. So I'm just going to very briefly touch on the pill. I'm not going to talk too much about this today, but the hormonal contraceptive pill, there's also a lot of research talking about different things. So for some people who have got premenstrual depression, the hormonal contraceptive pill can be really helpful in terms of flattening out some of those fluctuations in mood if it's taken continuously. So there is some research in that regard, but there's also research that shows for some people, again, who are perhaps more sensitive to different types of hormones, that taking hormonal contraceptives can actually increase their risk of depression. So I guess it's just about being aware that if someone has new onset depression, thinking about both their natural menstrual cycle as well as any external or exogenous hormones they're taking. So any change in hormonal contraceptive pill that might be a contributing factor. And the other area I'm not really going to talk about, but want to acknowledge is pregnancy. Again, a time of really significant psychosocial change. Life is completely changed over the course of pregnancy and becoming a mother or a parent. But in terms of the hormone profile, there are really significant hormone changes that happen during pregnancy and in the immediate postnatal period, and up depending if people are breastfeeding for extended periods in that postnatal time frame. So again, there's a lot of research that people will be aware of in terms of postnatal depression and the different factors that might be contributing to that, both hormonal and psychosocial. And so it's another time that females can experience changes in their mental health, as well as if they've got underlying sort of neurotypes, mental health conditions. Pregnancy can be a time of change. So some people actually report improvements in their mental health depending on what's going on for them during pregnancy, and whether this is related to sort of increases in estrogen, which we know, we talked a little bit about being protective in the brain and neuroprotective. There's different theories. Some people report not a huge change during pregnancy, but feeling particularly affected in that postnatal period. So again, something to be aware of. And there's obviously a hormonal change that's happening in addition to lifestyle changes around the pregnancy and postnatal timeframes. So what I wanted to focus more on today is menopause. So just so we're all kind of on the same page, I know we talk about menopause and perimenopause a lot, but just to provide some definitions. We have our reproductive years, and I showed you before how our hormones fluctuate in a cyclical pattern if you're not taking the pill over our reproductive years. And then we have perimenopause, and perimenopause can span 4 to 10 years. It differs for different people. And during perimenopause, the hormonal changes involve fluctuations in estradiol, our primary estrogen that we have during reproductive years, and a gradual decline as well in progesterone. And then we also see an increase in other hormones called luteinizing hormone and follicle stimulating hormone. And this keeps happening until we hit this point of menopause, which is defined or diagnosed retrospectively, but it's 12 months after someone's final menstrual period, someone hits menopause, and then from that day on, they're postmenopausal. But the point of menopause is the last menstrual period that someone has. So during this time frame of perimenopause, the experience of perimenopause is really varied. So some people experience nothing at all, about 1 in 5 people. 1 in 5 experience quite severe symptoms, and the majority of people will experience mild to moderate symptoms. And when we talk about symptoms, they're really varied. Just before I do that, just in case anyone is interested in how we kind of clinically define, or in research define, the different phases of the menopause transition, this is the gold standard. It's called the STRAW, which is Stages of Reproductive Aging Workshop. That's what it's based on. And it goes through the different stages of the reproductive years, the menopause transition, and postmenopause. So what we're talking about here is perimenopause, and the key criteria is changes in the menstrual cycle length until someone hits what I talked about before, of menopause, of someone's final menstrual period. So during the perimenopausal timeframe is when symptoms emerge for people, and I'm just highlighting some of the key symptoms. So the hallmark or stereotypical symptoms of menopause are the hot flashes and night sweat. So they're called vasomotor symptoms, and they're the symptoms that people speak about probably the most historically. But over recent years, we've learned more about other symptoms that people can experience, like the psychological symptoms. So that's what I'm focusing on today. I'll also note that in some cultures and for some people, menopause is not all negative, and it can be really an opportunity to reassess someone's identity and embrace the next phase of their life. It can be also, for some people, freedom from menstruation or menstrual pain. So not all negative. But I am going to talk about some of the negative mental health symptoms that people experience. So this is the menopause checklist. There are different versions of this around, but if someone is working with someone who's perimenopausal and they want to kind of get an overview of some of the symptoms that people might be experiencing, you can use checklists. You can ask people about this, just to provide some context about whether people, what sort of symptoms and experiences people are having as part of the perimenopausal transition. So starting with menopausal depression. So we know that perimenopause and menopause is a time of increased vulnerability to depressive symptoms as well as clinical depression. So some of the risk factors that have been identified for developing or experiencing a depression in these years is a history of sensitivity to hormone fluctuations. So that's someone who might have experienced premenstrual depression or postnatal depression, someone who's experienced stressful life events, or a previous history of depression. However, depression can appear de novo, like for the very first time during perimenopause in someone who has no history and in someone who doesn't have these risk factors. So it's a time where people become vulnerable. The symptoms of menopausal depression are a little bit different to a standard clinical depression. So in particular, women describe this fluctuating on-off type pattern where symptoms can be prominent and then they might not experience anything. And the symptoms can come out of nowhere. That's the experience people describe. The types of symptoms that are more common are things like anxiety, or even paranoid thinking. People talk about an anger that can be an outburst, or it can be an irritability or a frustration, but it can also be extreme rage. So this anger or rage that appears out of nowhere. Sadness isn't always the key symptom. Some people do experience a loss of interest and pleasure, but not always. And I mentioned paranoid thinking. The last few symptoms that are listed here, changes in sleep, decreased libido and sexual disturbance, a loss of energy and tiredness, trouble thinking, concentrating, brain fog. Those symptoms might be part of the menopause depression spectrum, but they can also be independent symptoms associated with menopause. So can be overlap between those symptoms stemming from a depression or coming independently and adding to that depression spectrum as part of the menopause transition. So together with Professor Jayshree Kulkarni, who I work with at her centre at Monash University, we developed this rating scale for menopausal depression called the MenOD, which you can access here. And the MenOD asks about the different symptoms that I was just sharing with you, and kind of loads onto these different factors representing the self, representing sexual changes, somatic changes, cognitive changes, and changes to sleep. So it's freely available and anyone can use that as a way of objectively measuring depression severity across the menopausal transition. So now I wanted to switch to brain fog and talk a little bit about brain fog. So this is something that I think has popped up in the media maybe in the past 5 to 10 years, and something that we're certainly learning a lot more about. So the term brain fog is not unique to menopause. It's a term, or brain fog is a term that's used in the context of things like long COVID, chemotherapy, pain. A lot of people use the term brain fog. And we wanted to drill into what do people mean in the context of menopause when they're using the term brain fog. So we've done quite a bit of research in this space. And one of the things we've done is ask people what sort of symptoms they classify as brain fog. How do they describe it? And the types of cognitive symptoms people talked about were things like poor memory, difficulty concentrating, a mental fatigue, difficulty planning and organizing, difficulty making decisions, difficulty multitasking, and time blindness, which was less commonly reported. So this was a survey we did, and it's an overrepresentation of brain fog because we specifically recruited people who identified with brain fog. So this isn't reflective of how common these symptoms are generally in menopause. But for this sample, you can see that things like brain fog or poor memory are occurring in a large majority of the sample. We also asked people to rate the severity of these symptoms, or how bothersome the symptoms are, from 1 being not bothersome to 7 being really bothersome and severe. And you can see for this sample, the brain fog symptoms are in that moderate to almost sort of slightly severe range. And if you look further down the list, you can see things like sort of night sweats and muscle pains, which we also associate with menopause, are experienced less commonly in this cohort. And also it's like the hot flushes are less bothersome compared to some of the cognitive symptoms. So those symptoms, we know they happen to people all the time, like having, poor memory or being forgetful, the kinds of symptoms of walking into a room and forgetting why, and losing your train of thought. It happens to everyone often, and they're not symptoms that are unique to menopause. But this study that was done in over 12,000 women, they were all nurses, it was conducted in Japan. What they found is that you can see that this was about forgetfulness and poor memory. You can see that it peaks in midlife, coinciding with menopause, both slight and severe degrees of poor memory and forgetfulness. So what we think is happening is that they're all common symptoms, but for some reason, during perimenopause, these cognitive symptoms become more common, more problematic. So we did some other research where we used this scale called the Everyday Memory Questionnaire, and it's a 13-item scale that people can use to self-report their symptoms, and we've now validated it in a perimenopause cohort and a postmenopausal cohort. And what we found is we administered this scale to women who are premenopausal, peri, and then postmenopausal. And you can see the orange bar, the perimenopausal cohort. You can see things get worse. A higher bar, higher score is worse, everyday memory problems. And the types of everyday memory problems people were reporting is that tip of the tongue phenomena, so word retrieval difficulties, and having to check whether you've done something you should have done. So this was being experienced by perimenopausal women. At least a third of them were experiencing this once or more per day. So I just wanted to take a step back and think about, well, why is this happening and what happens? What is everyday memory? What is, word retrieval? What is it when we forget why we walked into a room? Is it really memory that we're talking about? So I just wanted to take you all through the steps that are involved in everyday memory. So we start off with, at any point in our day, we're always bombarded with a variety of sensory inputs. We see things, hear things, smell things, taste things. So our sensory inputs are happening all the time. And alongside that, we often have internal thoughts. So we have without any external sensory stimulation, we have lots of thoughts that are going through our mind. So there's a lot going on at any point in time. And we have to decide where we're going to allocate our attention, because we can't possibly attend to everything all the time because we'd become very overwhelmed, which can happen in some individuals, which I'll talk about a little bit later. So we first of all have to allocate our attention. So if we're trying to learn a new piece of information or remember why we've walked into a room, we have to allocate our attention to that task, because if we don't encode it, we haven't learnt that piece of information. And sometimes we juggle things in our working memory, which is sort of capacity limited, and it's just juggling piece of information in our mind. It might be, again, why we're walking into a room, we've got to go and get our keys, or someone told us something that we need to do for work and we've just got to write it down so we can remember to do it later. So there's only so much you can ever juggle in your working memory and hold in your mind at one time. So that's another factor that might contribute to lapses in everyday memory. After we've attended to a piece of information and heard a new piece of information, we have to encode if we want to remember it later, so not just to walk into a room and then forget about it, but if we really want to encode a new piece of information, we have to really focus our attention on it and encode that new piece of information. And then after that, we have to store the information somewhere in our mind, which is a chemical process of forming a new memory. And then later, we retrieve that piece of information. And so sometimes people report that their memory is impaired and they're talking about retrieval, that they can't remember things, they can't retrieve pieces of information. But actually, sometimes the issue or the change is with their attention and juggling things in working memory. And it feels like a memory problem, but it's actually more related to attention and working memory. So I just wanted to share that, just to, when I talk about tips and strategies at the end, is relevant to understand the different steps that are involved in memory. So in terms of menopause, just recently we wanted to better define the cognitive symptoms of menopause because we felt like people were using this general term brain fog, which the community feels like is a good term, but we felt like to progress research and clinical work, we needed a better definition that's a bit more operational. So we've defined menopausal cognitive symptoms as a self-reported impairment in one or more cognitive areas. So it's when people say that their memory or their attention or something isn't as efficient. But importantly, it's in the absence of a notable objective cognitive decline. So this means when we do a neuropsychological assessment on something like memory, there isn't an actual decline in that. When we look at big groups of people and compare groups, we do see a subtle lowering of learning efficiency in the menopausal group compared to the non-menopausal group that relates to the subjective cognitive symptoms. So people who have higher degree of subjective cognitive symptoms are more likely to experience a lower degree of learning efficiency. However, mostly at an individual level, people perform within expected ranges on a neuropsychological task. We also note in this definition that the experience of cognitive symptoms can fluctuate over the course of the day, or if someone still has a menstrual cycle, over the course of their menstrual cycle. It can cause mild to substantial distress on people's everyday life and quality of life. But unlike dementia, for example, it does not result in any sustained changes in someone's capacity to perform activities of daily living. So it's quite a long definition, but we felt like it kind of captures the essence of what the cognitive symptoms are in the menopause or perimenopausal years. So clinically, some of the clinical considerations that seem to pop up when someone is experiencing cognitive symptoms during perimenopause, there's probably two key things that people ask, and it's often people who may not have even attributed their cognitive symptoms to menopause. So they're experiencing cognitive symptoms, they're searching for an explanation or answers as to why they're experiencing these cognitive symptoms. And the most common things people say is this dementia or the early stages of a dementia process? Or is this ADHD? Do I have ADHD? Have I always had ADHD and it's just presenting for the first time? So I'm just going to touch on these 2 points next. So in terms of, is this dementia? I did some work with a colleague at the UCL University in London. Her name's Amy Spector, and we've done some work looking at differentiating the key factors that really differentiate early stages of dementia from menopausal brain fog. So one is who it affects. So obviously dementia is something, it's more common, dementia of the Alzheimer's type in women or females, but they're generally over the age of 65, whereas menopausal brain fog is impacting anyone with ovaries who are primarily aged, perimenopause, generally the median age is 51. So generally the menopause cohort are younger. So the course and progression of dementia, it can have a sudden or gradual onset, but it is chronic, it is progressive, and there's deterioration over time. This is not what we see in menopausal brain fog. So like we've incorporated this into the definition we've created, but it can fluctuate, but it's unlikely to be associated with deterioration, and it typically improves post-menopause. So the key symptoms of dementia can be really varied, but in terms of the Alzheimer's presentation or Alzheimer's pathology, it is disturbances of primarily memory, the ability to learn new pieces of information, but there can also be changes in orientation, in comprehension, in language, in different areas, whereas the symptoms of brain fog are more that day-to-day, everyday memory. So, difficulties recalling words, or word retrieval. There might be sort of misplacing items, difficulty concentrating, losing train of thought, forgetting day-to-day things. And the next key and last key differential factor is the impact on daily living. So in dementia, there is an impact that starts off obviously mild, but progressively becomes more severe, and people cannot continue with whatever they were doing in terms of their activities of daily living. Whereas menopausal brain fog, while it can have an impact on quality of life, on self-esteem, on people's sense of their capacity to work and do things, it doesn't generally impact someone's ability to live an independent life. And the other differential factor that we noted in the paper as well is that in menopausal brain fog, it's often the woman herself who's most concerned about her cognitive symptoms, whereas in dementia, because of the loss of insight that can happen, it's often someone who cares for that person, their partner, their child, who is more concerned about the dementia symptoms. And if dementia is happening, if there is a young onset dementia, which exists, but it is rare, it's often accompanied by mood changes and behavioral changes as well. So then the next sort of question that people ask, particularly if they've got sort of symptoms during menopause in terms of that are a bit more executive in nature or a bit more related to attention, difficulties sort of focusing, difficulties juggling things, people sometimes question, is this ADHD? So I just wanted to talk briefly about sort of what is neurodivergence and what do we know about the interaction between neurodivergence and menopause. So to begin with, the term neurodivergence is a term that comes more out of the whole sort of social disability space and less so out of the medical pathologizing space. And it's the idea that the majority of the population are neurotypical and they have what we call neurotypical brains, and then a minority of the population, their brain types are different. They're neurodivergent. And within that neurodivergent category are ADHD brain types, autistic brain types. It can include people with other neurodevelopmental conditions that might be differences in their reading or their praxis, so dyspraxia or specific learning disorders. So that's what the term neurodivergence means. And there's a bit of literature that's showing that neurodivergent individuals are more likely, or neurodivergent women are more likely to experience an increase in a whole range of menopausal symptoms. So again, this increased sensitivity to hormone changes is one of the hypotheses. So this research has been done primarily in women who are autistic and women with ADHD, and they show that they experience more menopause symptoms. And then there is also this question of whether menopause can exacerbate or unmask a neurodivergence. So I just want to talk a little bit about ADHD and then come to that question. So switching more now to how we diagnose ADHD, which is within the medical pathologizing banner, because we use the DSM. So it is inattentive symptoms, so the attention deficit component, and or the hyperactive. So you can have either an inattentive presentation, or you can have a hyperactive impulsive presentation, or you can have a combined presentation. So inattentive symptoms are things like distractibility, overlooking details, forgetfulness, losing items, difficulty regulating attention, difficulties regulating focus. These are things that can happen to everyone all the time. They're, again, not particularly unique or odd experiences or characteristics. The hyperactive impulsive symptoms are being impulsive, fidgety, restless, completing other people's sentences, so that impulsive sense of wanting to jump in and finish someone's sentence, difficulties waiting your turn, talking excessively. So, and people who have a hyperactive impulsive presentation of ADHD often describe this feeling like they've got a motor that's on inside of them and they cannot turn it off. So it can be motor as in physical, but it can also be in terms of their thoughts. Importantly, in terms of a diagnosis, you need to have 5 of the 9 symptoms that are listed under either the inattentive or hyperactive impulsive category. They have to be neurodevelopmental. So even if you've not really been hugely affected by the symptoms throughout your life, there has to be evidence that those symptoms were there during childhood. This is a diagnostic criteria. The symptoms have to be present in 2 or more settings, so not just at work or not just at home. And there has to, most importantly, be clear evidence that the symptoms interfere with or reduce the quality of someone's life in terms of social, academic, occupational, relationship, their functioning. So that's the diagnostic criteria that we have to work with when we're thinking about whether someone who is perimenopausal, whether it is an ADHD or whether it's like a new onset brain fog. So that I can, again, if people have questions about that, I can talk more about that. But I'm just going to speak briefly about why we can experience either an exacerbation of something like ADHD or brain fog for the first time or depression for the first time during menopause. So I've talked a little bit about the hormone changes, the fluctuations in estrogen and the decline, and how that can impact the brain. And there's also neuroimaging studies that show changes in brain structure, in energy metabolism, in connectivity in the brain across the perimenopausal years. So that's one contributing factor. Then there can be other menopause symptoms. So on its own, if anyone, I mean, everyone is aware, if you're sleep deprived, it's going to impact your mental health and your cognition or cognitive clarity. So sleep can often change as a symptom of menopause, either from night sweats or other reasons. Hormonal changes can change how your sleep, how good your sleep is. So sleep deficits are a really common part of the menopause transition. There can be physical symptoms or pain or hot flushes. So these can all independently affect someone's mental health during menopause and lead to some of the symptoms that we've been talking about. Then there's personal factors that can potentially alter this relationship, whether someone, for example, has a history of depression, what their genetic makeup is, whether they're sensitive to hormone fluctuations. So they can all play a role, particularly whether someone has experienced early life trauma. That's thought to play a significant role. And then there's life stress. So for many women who experience menopause, the age of menopause is midlife, which is just a really busy time in our modern society for a lot of women. So that is also a contributing factor. If someone is stressed and stretched, that can also have an impact. So finishing up last 5 minutes or so with what to do. So I think for anyone who is working with someone or who is aware of someone experiencing cognitive symptoms, mood changes, exacerbation of things during menopause, they should be encouraged to talk about different treatment options with the healthcare provider, and their experiences should be validated. These are really real experiences for people. Another thing that's important, if there are sort of new onset cognitive problems or mood problems as well, it's really important to also talk to your healthcare provider, because there could be other reasons for this that are reversible or can be treated. So that's also really important. In terms of treatment options, there is menopausal hormone therapy. So that is really great as a therapy in terms of treating hot flushes, night sweats, but it can also be really helpful for depression and for cognitive symptoms for some people, but we're still developing our evidence base. So currently the clinical guidelines suggested as a potential treatment for depression, not for cognition, but I think it's more because we don't have the evidence base, we don't have the clinical trials to support hormone therapy for cognition, but anecdotally, a lot of women do find significant benefits. Antidepressants are sometimes useful for depression, particularly if it's pre-existing. There's psychological therapies like cognitive behavior therapy, which can be beneficial for both the mental health symptoms, but even for hot flushes, there's an evidence base that sort of changing and reframing your mindset about the hot flushes can help reduce the anxiety that can come with them and the experience of hot flushes. And also important to talk to a healthcare provider about what symptoms are in the mix and what can be managed in different ways. And then there are really practical strategies, which I'm just going to very briefly touch on. So and lifestyle choices, that's what I'll finish on. So in terms of practical strategies, if someone is experiencing challenges with their attention, there are lots of things people can do, but primarily it can be really helpful to reduce your mental load, reduce how much information you're trying to juggle in your working memory, and encourage people to be present, to be mindful, to be in the moment so they can attend and take in new information. There are lots of strategies to help with memory. Some are external, what we call compensatory strategies or compensatory strategies, where you can use calendars and diaries and write everything down so you're reducing how much you're relying on your memory. And then there's more internal strategies which help enhance how much you can remember. So repeating information, trying to visualize new things, that can be helpful. And then the tip of the tongue, which is that word retrieval challenge, which is really common, encouraging people to use synonyms to describe what they're talking about and try not to get too anxious and fixated on finding the specific word. If they need to, the theories to use to kind of go through the alphabet, but not like ABC for trying to find a word, but using the phonetic sounds at, Berker, and that can potentially help retrieve that word. So now the last thing I wanted to finish on is that while the menopause transition can be a period of vulnerability, it's also an opportunity, if you're feeling well enough or people you're working with are feeling well enough, to think about building their brain health and their cognitive health. And there's a great evidence base of what can be helpful. So exercise is the first one. So any form of exercise, people know, and there's great evidence for exercise having beneficial effects on mental health, on cognitive health, short-term and long-term effects. So the gold standard of what people are aiming for, with exercise is 150 minutes a week of moderate intensity exercise plus 2 strength training sessions. So it is quite a bit. So always just starting with whatever people can manage. Sleep is the next one. And sometimes this is an easy thing to say, but it can be really challenging for people who have sleep disturbance. But there are lots of great resources available. So for during menopause and all times in life, there's a cognitive behavior therapy for insomnia, CBTI, that have free online programs that do have an evidence base for insomnia, but also specifically during menopause. So this can be really helpful for people in terms of, again, reframing their thinking and building good sleep hygiene routines. So there are things that can be done. People don't have to just suffer with poor sleep. Thinking about this phase of life as a time to prioritize self-care, that can be really important. Thinking about what you're consuming, so healthy, balanced diet, minimizing alcohol, so not using alcohol as a coping strategy, considering menopausal hormone therapy as a potential therapy to help with different symptoms, stimulating your mind in whatever way, that's always encouraged, but doing that in an enjoyable way. And then the last one is staying socially connected. Again, lots of evidence for social connections and the benefits for that, for mental health, cognitive health, brain health more broadly. And also in terms of brain health, thinking about, all the physical, vascular kind of risk factors and health factors that can be really helpful for brain health as well. So controlling cholesterol and blood pressure and things like that. So I think I just have one last slide, which is this fact sheet that we co-designed with perimenopausal women and evaluated, which is just a really broad and brief overview of what is brain fog and what are some of the, or what are the cognitive symptoms of menopause and what are some of the tips to help manage that I've kind of talked about today. So that was the last slide. This is a link to our website where there is more information if anyone is interested. But I'm going to stop sharing now, and I'm very happy to answer any questions.
Thank you, Caroline, for delivering such a compelling and informative presentation on women's mental health and neuropsychology. And thank you for everyone who joined us today for the vital conversation on women's mental health and neuropsychology, an update on how hormonal shift impacts cognition and mental health. Your engagement and curiosity truly enrich this discussion. On behalf of the Mental Health Foundation Australia, I would like to extend our heartfelt gratitude to our speaker and to each of you for your time, attention, and dedication to mental health advocacy. We encourage you to continue exploring this topic and stay connected with our community as we work together to promote awareness, understanding, and support. Until next time, take care of yourself and each other. Goodbye for now.